I'm going to try not to talk too fast. So we did want to just take a moment on our disclosure because we really would like to discuss the expected outcome. Certainly we want you to be inspired, but another outcome that would be a positive one for our presentation if you think this is a great idea and can really use it. So also a couple little notes about our project that we're talking about today. It was funded by Robert Wood Johnson in the first round of public health law research through Temple University. And this is just a small piece of a much larger study that I hope will illustrate a little bit of what we're talking about today and the connections between practice and research. So I think one of the ways to conceptualize how to find a research question that makes this good match is to think about the need for practitioners to have a mirror of their system. Our local public health directors live in their sometimes own little worlds and know their own agencies really well, but don't necessarily have a full view of the entire system. And so I think what you'll hear today is a story where we took that mirror and held it up to the system to show them ourselves as practitioners what's going on, what great work are we really doing, and how can we improve on that and use that for the future. So I think many of you know that there's been a lot of change in the Colorado public health system due to a law that we put into effect in 2008. And two of the big drivers in that law in the short term were a restructuring of local public health. So we went from a two-tiered system to all local public health agencies are the same, as much as they can be, I think, with a law change. And then there was a call for, in that law, a set of core services that all public health agencies must provide or assure. So you can imagine that made our practitioners a bit nervous. Am I doing what I'm supposed to be doing? What are they going to call core services? What does this mean? And there was some fear that this was a call for regionalization, right? We have a lot of very small public health agencies serving rural frontier areas. So there was a perception or a fear that this was all about making those agencies turn into district public health agencies. So I think that was something that was driving the practice community. And our interest was to find a research project and some researchers that could help us see what is that level of work that we're already sharing across jurisdictions. We'd heard little stories, anecdotes, snippets here and there. Well, I don't need to become a district. I already am sharing my environmental health services with my next door neighbor. And by the way, my county commissioners don't want to be a district with them. And I'm already sharing WIC services with my other neighbor on the other side, but there was no, again, mirror of what does this system really look like. So I think now I'm going to toss it over to my research partner.
So you saw Lisa, practitioner, use the hand motions, the mirrors. So trying to translate that, Julie, researcher, thinks, okay, we want to systematically describe, accurately, representatively, what kind of sharing is occurring across jurisdictions. So we conducted a web-based survey, which was administered to all 54 local public health agencies in the state. We were able to determine that half, 27, actually took a lead role in a regional approach. Two of those only took a lead role, whereas 25 had approaches where they were the lead and other approaches where they were the receiving partner. Regional approaches was defined in the survey to constitute an employee, project, resource, or other strategy that got shared across jurisdictional lines or span jurisdictional lines. And then the survey was really focused around the purpose of that sharing, the motivation, who was involved, how it was evaluated, how it was funded, legal barriers to these kinds of arrangements, what type of agreement, whether it was formal or informal, sometimes a handshake, sometimes a legal document, and then how they went about ongoing decision-making. In addition, a purposeful sample of public health directors was selected purposeful being to represent a range of size of local public health agencies, types of services being shared, and how long they'd been in existence. And the key informant interviews then went in more depth on the process for sharing and the challenges that arose. So what we found, it's hard to read, but the point of the first graph is really to show that it shows the number of shared approaches, and along the x-axis along the bottom, you see that it spans a lot of different types of services. So the most common on the left is environmental services that are being shared between jurisdictions. What was also interesting is that a given jurisdiction might share one service with a neighbor to the south and a different service to a neighbor on another direction. So it wasn't always the same partners sharing services. It depended on the type of service it was and some conditions which Lisa will actually describe in a little more detail. The top reasons for initiating a shared service was that the service hadn't been available before in a given jurisdiction, that there was some type of funding on the table. Either there were environmental fees or there was funding from the state for a given service that allowed the service to actually be provided. And then in some cases, there was really a local champion that really made this happen. Who was involved? The public health directors were involved in the actual negotiation of this sharing. In about a third of the cases, the county commissioners were involved, community partners to a smaller extent, and then down around 13%, you had attorneys and human service directors involved. So at this point, I'm going to turn it back to Lisa.
So this obviously is a tiny snippet just to give you an example of some of the really rich, terrific information we learned. And so we certainly saw a lot more than our anecdotes. We realized that, wow, every jurisdiction is participating in some level of sharing with others. We did have a pretty specific definition about what sharing was, and we made them sort of conceptualize their work in that. And some of them said, well, I thought I shared, but I'm not sharing quite to your definition. So there's even more sharing a little outside of that definition. So that was really wonderful for us to be able to show the map and some of those pieces to the directors. I think one of the best things we learned, and this is a bit in to explain why maybe a district isn't the best way to go for everyone, but that there's nuances in every community and every program that mean the strategic way that they're currently sharing services is useful. Now, there's probably about another 10 research projects or more that we could do around this sort of preliminary description. But when we think about community need, cost, funding, political will, those all come into play in these shared services. So we have a county that may say, you know, my county commissioners don't want me to be doing robust family planning, for example. Happens in Colorado for sure. But I could do environmental health services with you. And we need some of that in our community, and we can charge fees. So we start with environmental health services, and then maybe we move to other services, but we could be strategic about what works. In Colorado, some of that strategy is around where our roads go. Didn't realize about New Hampshire and your road problem, but certainly we have mountains in between many of our roads, and so contiguous counties aren't always easy to get to throughout the whole year. So some of those services you can actually use from your neighbor that you can get to all year round. So those little strategy reasons why our directors choose the shared approaches that they do was something that we could show them that they're doing and then help them learn ways to do that even better, right, in terms of improvement. Some of the, I think, unintended positive consequences of this project have really propelled our practice-based research network, our team and such. So I think we have certainly expanded our research team and our capacity to do this kind of work, this figuring out what practice needs to understand, figuring out a way to research that, and it really has propelled us. I think now with this particular project, we have a good baseline collection of approaches. We can continue to track those, collect new approaches, and have a better idea of what's happening in our entire system, and be able to provide that immediately to our practitioner friends. And then in terms of sharing, we've shared the models with the directors. They've shared amongst each other, oh, how are you doing that? How are you sharing work? How did you make that happen? So they're developing networking relationships that way. We've used it in conversations with state leaders who are making decisions to guide our system change, to say, this is an option for us. Maybe we don't all need to turn into districts. And then we've been able to share this with other states, with FAB in terms of their multi-jurisdictional accreditation, with the public health law teams looking at the legal aspects of regional approaches. So it's been a really great project for us.